Hello, I'm Angie Chappell,
I'm Emily Davis.
And I'm Pamela Long.
and we are presenting multiple myeloma. We start with the etiology of multiple myeloma. The cause has not yet been identified. Although it is not a hereditary disease, research has shown chromosome abnormalities in which there are missing chromosomes in about half of those diagnosed with multiple myeloma, specifically in deletion of chromosome 13. Abnormalities have also been found in the expression of some genes and are associated with risk for early relapse of multiple myeloma. Although there are no strong connections, multiple myeloma has been known to develop in individuals with a weak immune system. Exposure to chemicals and radiation may also be a risk factor. Therefore, it is suggested that multiple myeloma could be a result of several risk factors coinciding.
Next, we move on to the pathophysiology. Multiple myeloma is a hematologic neoplasm, specifically a malignancy of the plasma cell, which is also the B lymphocyte. Plasma cells secrete proteins that aid in the production of antibodies which fight infection. The proteins that are secreted by the plasma cells are called immunoglobulins. With multiple myeloma, the plasma cells produce and secrete an excess amount of immunoglobulin known as monoclonal protein, or M protein. The M protein produced by the myeloma plasma cells is non-functional, which means it does not aid in antibody production. Functional immunoglobulins are still produced and secreted by non-malignant plasma cells, but they're in decreased amounts. The excessive secretion of non-functional proteins, the M protein, in coordination with the decreased secretion of functional proteins, albumin, negatively impacts the production of antibodies needed to fight infection. A patient with multiple myeloma will present with blood test results of elevated M protein levels, decreased albumin levels, and elevated total protein levels. The proliferation of myeloma plasma cells increases osteoclast activity, which destroys the bone while simultaneously suppressing osteoblast activity, thus preventing new bone growth, all of which leads to the bone lesions so prevalently found with multiple myeloma. The image that you are looking at shows a hematopoietic stem cell. It shows the normal differentiation here and a normal plasma cell and the antibodies produced. And it shows a multiple myeloma cell right here, which you can see is significantly different from the normal plasma cell. You can also see that the antibodies produced are abnormal. They are non-functional. Next, we will move on to the signs and symptoms of multiple myeloma.
Signs and symptoms include bone pain in the back and long bones, fatigue and weakness, fever, bleeding, pathological fractures, spinal cord compression, hypercalcemia with signs and symptoms of nausea, fatigue, and thirst, thrombocytopenia, and neutropenia. Hyperviscosity signs are headache, bruising, ischemic neurological symptoms, increased erythrocyte sedimentation rate, and anemia. As myeloma cells quickly proliferate, red blood cell production is greatly decreased. Production of white blood cells is also reduced, causing increased risk of infection. There's bone damage in multiple myeloma. Rapid growth of myeloma cells inhibits osteoblasts, damaging the bones and preventing new bone growth. Osteoclasts are further activated, causing increased bone destruction. Renal failure can occur in multiple myeloma. Excess M proteins secreted by the myeloma cells reduce the kidney's ability to filter the blood. Additional strain is put on the kidneys to eliminate the extra calcium in the blood. Overproduction of light chains, also called Bence-Jones proteins, a plasma cell, form obstructing cast in the distal tubules.
So diagnostic testing that we would do for multiple myeloma. Hypercalcemia can be a sign of multiple myeloma. Creatinine and BUN can show renal failure, which can occur. Albumin levels and monoclonal protein in multiple myeloma, a globulin gap can occur. This is when the monoclonal protein levels are high and the albumin, the good protein levels, are low. A CBC will show low hemoglobin, low hematocrit, and low red blood cells, leading to anemia. Electrophoresis may be ordered if the blood results point toward multiple myeloma. A serum protein electrophoresis detects monoclonal protein. Higher levels indicate the extension of the disease and is used to stage the disease. Urine protein electrophoresis determines the presence of levels of monoclonal protein and FLC, also known as Bence-Jones protein. A bone marrow biopsy takes a sample of solid bone tissue for abnormalities in blood cells and signs of disease. And imaging may be ordered, such as X-rays, MRI, CT, or PET scan. The treatment for multiple myeloma. Stem cell transplant is the most effective treatment available. They may use the client's own stem cells or a donor's. The stem cells are collected, frozen, stored while the client undergoes chemotherapy to destroy the cells in the bone marrow. Both the healthy and diseased cells are destroyed. The stem cells are then thawed and injected into the client's vein, where they travel to the marrow and begin producing healthy blood cells. This treatment does not cure the disease, but it can extend the client's life. Plasmapheresis is a procedure in which the blood is removed from the patient and sent through a machine that separates the plasma from the blood cells. The normal blood cells are returned to the bloodstream along with donated plasma or a plasma replacement. Plasmapheresis does not prevent new antibodies from forming. Chemotherapy side effects include hair loss, mouth sores, anorexia, nausea, and vomiting, low blood counts, which can lead to an increased risk of infection, bruising and bleeding due to the low platelets and thrombocytopenia, fatigue and or shortness of breath due to anemia caused by low red blood cells. Corticosteroids is another treatment. Dexamethasone or prednisone are often given with chemotherapy to reduce the side effects of nausea and vomiting. Side effects of these drugs are high blood sugar, increased appetite and weight gain, problems sleeping and mood changes, irritability. When used long-term, they can suppress the immune system, which leads to a risk of infection and weakens the bone. Interferon is a hormone-like drug and can help extend remission. Bisophosphonates down and prevent further bone damage, slow down the growth, and prevent further bone damage. This medication can cause osteonecrosis of the jaw, where part of the jawbone dies. So it's very important that the patient keep up with their dental care. Immunotherapy are antibodies used to attack cancer cells with patients that have not had success with other treatments. Daratumumab and elotuzumab are two antibodies that target multiple myeloma cells. Daratumumab is a monoclonal antibody that attaches to the CD38 protein, which is found in myeloma cells. It is thought to kill the myeloma cells directly and to help the immune system attack the cells. Others, like thiodomide, have also been used with multiple myeloma. However, research done by Terman, Love, and McCullough and Sandifer in 2008 has shown that it can cause painful nerve damage called multiple myeloma peripheral neuropathy. The neuropathy can be severe and not go away after the treatment ends. There is also a risk of blood clots in the legs that can lead to pulmonary embolism. Radiation therapy is another treatment. It's a cancer treatment that uses high-energy X-rays or other types of radiation to kill cancer cells and keep them from growing, which helps lessen the pain and prevent further bone damage.
Next, we move on to the outcome. What is it that we want to see in our patients who are treated for multiple myeloma? Although there is no cure for multiple myeloma, there is treatment and management of symptoms. The outcome depends on the systems affected by the disease. The more systems affected, the poorer the patient prognosis. One study says patients with a good prognosis have a median survival rate of 62 months, whereas those with a poor prognosis have a median survival of 29 months. With current treatments, patients are able to live longer lives, but symptom management and treatment tend to take over a large portion of their lives and affect the quality of their life. For this reason, it's important for patients who have multiple myeloma to have the support they need to successfully manage their symptoms, whether it's from their families, physicians, nursing staff, or support groups. Some symptoms that need to be managed are as follows. Patients with multiple myeloma experience chronic fatigue and have a continuous risk for injury and infection. One study published in 2014 by Stevens, McKenzie, and Jordans indicates that quality of life and duration of survival require extensive work and determination by patients. The study went into great depth with the necessary steps and different types of work that the participants had to endure throughout their diagnosis of multiple myeloma. In conclusion, the study, entitled The Work of Living with a Rare Cancer, Multiple Myeloma, the participants reported the need for constant effort, planning, and organization regarding the risk for infection and injury when living with multiple myeloma. Participants also stressed the importance of emotional toll that this disease process takes on both the patients themselves and their caregivers. The outcome of all of this work and dedication and determination is understanding their limitations and effectively managing the complications of the disease.